On this episode of the ASC Podcast with John Goehle, we discuss vaccine mandates, recent and upcoming virtual conferences, and in our focus segment, review the proposed Medicare Quality Reporting requirements related to OAS-CAHPS and Patient Satisfaction, discuss patient communications and engagement, and interview Spencer Kelpe with Dialog Health regarding technological advances in patient communications.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. This episode of the ASC Podcast with John Goehle is sponsored by Dialog Health. Dialog Health's business text messaging platform is transforming patient engagement and employee communication. For more information about how Dialog Health can help your ASC, visit dialoghealth.com. That's dialoghealth.com.
Welcome to episode 141 of the ASC Podcast with John Goehle for October 11th, 2021. We're recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies and recognized as one of the nation's leading experts in the ambulatory surgery industry. John is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory accreditation and finance issues.
Well, here we are, recording on the Monday after our wonderful medical director conference, first in the industry. Nobody has ever done it before, and we had, about 15 participants in the program. Was quite surprised that we weren't quite sure how well it would go over. Obviously, we would like it to be 50 people, but for our first try, it wasn't too bad. So thank you to all of the medical directors that joined us. It is something we're going to continue doing. We're talking about whether we're going to do another one, like more than one per year, or whether one a year is enough. And we did record the educational section of it. We didn't record the dialogue between the different medical directors, like the breakout. But we'll make that available shortly for sale for anybody that wants their medical directors to learn what the job of a medical director is. So I thought it went off very well. And of course, we're now preparing for our upcoming conference.
The Conditions for Coverage Conference.
That's right. The Medicare Conditions for Coverage and Interpretive Guidelines Conference, to have its long name there. And that's going to be in 2 weeks. So it's actually a week from Friday. So if you haven't signed up yet, make sure you go to our website at ascpodcast.com.
I think that can be useful for anybody that works in an ASC. That's kind of the basis for everything. So
it's probably the one conference that I could say everybody could probably go to. Anybody within your organization, anybody that's interested in starting an ASC, anybody that's been doing ASC for a very long time. And, we have seen it's actually going to be very well attended. But we'll give you more information at the end of the podcast of the date. But to sign up for it, if you're so anxious that you want to sign up before the end of the podcast, go to ascpodcast.com. And, of course, our boot camp is coming up. Our November boot camp for nursing directors is coming up. Sue and I, we just came off the tour, shall we say, of state associations there, Ohio, New York. I was out in Texas also. And we really had a wonderful opportunity to talk to a lot of individuals that might be interested in signing up. So we have a few more people signing up, and we still have a little bit of time. But again, if you're interested in having your nurse manager, or if you're a nurse manager is interested in learning more about the position and to increase your skills there, go to ascpodcast.com. So we got some recent news. Do you want to start with the it's kind of interesting news coming out of SPH Analytics. They, for those that are not familiar with SPH Analytics, they do patient satisfaction surveys for surgery centers. And they recently did a study. It's actually from May. I'm sorry. It's been
still applicable.
Yeah, it was something that I saw that we really hadn't talked about before in conjunction with our friends at the New Jersey Association. So, Sue, why don't you tell us about what they found?
So this looks like good news. More than 99% of patients feel as safe today as they did pre-COVID, according to a just-released study conducted by, as you said, SPH Analytics for the New Jersey Association of Ambulatory Surgery Centers. Among patients who had a procedure performed at a New Jersey-based ambulatory surgery center between September 2020 and March 2021, more than 99% strongly agreed that they felt safe at the New Jersey-based ASC that they had visited. This is compared to the more than 99% of patients who strongly agreed that they felt safe when visiting a New Jersey-based ASC between August 2019 and February 2020, before March 2020 when elective surgeries were put on hold by executive order as a result of the COVID-19 outbreak.
You know, what's fascinating about this, too, is that this is, there's over 15,000 respondents. I mean, this is very statistically valid. So I think, Jeff Shanton, our good friend over at New Jersey Association, said, that the ASC industry in New Jersey was hit hard by the COVID-19 pandemic. And since the vast majority of procedures performed by ASCs are for elective surgery and diagnostic procedures, visits to New Jersey's ASCs came to a screeching halt during the pandemic there. This, coupled with the fact that the New Jersey and the surrounding areas were impacted more severely by COVID-19 than other parts of the country, made this an even more challenging period for ASCs in the state. So his point really was that that's an incredible statistic given the specific challenges that they had during the pandemic and how heavily. I think New Jersey still has the highest rate of death in the country per 100,000 individuals. So kudos to New Jersey. And of course, they only did the study for New Jersey, but I have to assume that probably is a statistic that would be, valid across the country too. And Sue, let's talk a little bit about vaccine mandates. So we know that the administration has stated that they will require COVID-19 vaccination of staff within all Medicare and Medicaid certified facilities to protect both them and patients from the virus and from the more contagious Delta variant. What they indicated is facilities across the country should make efforts now to get healthcare staff vaccinated and to make sure that they're in compliance with the rule, before it takes effect. Now, CMS is working with the CDC to issue emergency regulations. I keep checking the CMS website to see when that gets issued. I suspect there will be some press releases coming out at that same time. But as of the recording of this on October 11th, those interim rules or those emergency rules have not been issued. So what's going to happen is CMS will develop what we'll refer to as an interim final rule with a comment period that will be issued, again, sometime here in October. And they expect that all certified Medicare and Medicaid facilities will act in the best interests of patient and staff by complying with the new COVID-19 vaccination requirements. So I think the important thing is we know the rules are coming down the pike. We also know that many states are already implementing this. For example, New York and New Jersey, two states in which we have quite a bit of knowledge, both have implemented mandatory vaccination rules with different nuances there. For example, in New York, they really don't allow any exceptions except for medical exemptions. They are currently under court order to accept religious exemptions until at least the end of this week, the week beginning the 11th. So I think we should all be prepared for some level of national vaccination mandate when it comes to healthcare institutions. But the other interesting thing, of course, is that President Biden indicated that he is going to order OSHA to establish regulations for large employers. So he asked the Occupational Safety and Health Administration, OSHA, to write rules that would require companies with more than 100 employees to mandate coronavirus vaccinations or weekly testing, and a mandate for providers, of course, that accept Medicare and Medicaid to mandate those vaccinations. So this is always a lengthy process for OSHA, and it could take quite a bit of time, though we do expect it to be coming out shortly.
And that the penalties can be so severe with OSHA that it's a little unnerving, I think, that they're the ones in charge of this.
Yeah. Well, and they, the other, as you said, the issue with OSHA is they can fine you and they can survey you. And if they come out and do a survey and they find other things in addition to the vaccination mandate, that could be even more severe. So this is certainly something that we're going to have to keep a very close eye on. So of course, the question begs, why did I bring this up? Why did I bring up the section about companies with over 100 employees? And the simple fact is, this is going to impact us also. mainly because of the supply chain. And I have mentioned this before, but we have to be very concerned about national companies that have more than 100 employees, or even your local companies that have more than 100 employees, for which we are reliant on their supplies. Yeah. We're already seeing issues with the ports in Los Angeles, for example. We're already seeing issues with truckers. And this was even before the mandate came out. They just don't have enough people to transport all of our supplies and to unload those supplies and to get them that final mile, as I say, to our surgery center. So I think the vaccine mandate is going to have repercussions all across the supply chain, which could impact our ability to get supplies. I'm already hearing anecdotally that we're starting to see allocations of certain supplies to our surgery centers, and I think it'll affect the drugs also. Interestingly, analysts at Goldman Sachs estimated last month that the vaccine requirements that were announced by the White House would apply to about 25 million unvaccinated workers in the United States. And I think I read somewhere that they believe that number has been cut in half already. Threatening this has made a lot of people step up. But still 12.5 million people, if that's true, that are unvaccinated, that, if they decide not to work, then we've got some significant problems. This is what I've been saying all along. Even in our industry, 8%, which I think is the last number I saw, of unvaccinated workers across the board. It's a lot of people. It's a lot of people. Yeah. It doesn't, even if it gets down to 1%, it's still a lot of people.
Especially when everybody's always short-staffed to begin with.
Yeah. Right so now. I think this is something we've got to be prepared for, develop some emergency preparedness programs for how to deal with staffing. I think we mentioned this in our last episode, that you really want to, start figuring out what you're going to do if, number one, you can't get supplies. Number two, if you don't have enough employees, you're going to have to start rationing your physician's access to, operating room time. So we have an interesting episode today, don't we? It's something we've never really talked about, which are, so we're going to talk a little bit about patient engagement, patient satisfaction, and I thought I would also kind of start the conversation with a discussion of OAS-CAHPS, which we've been concerned about what it's going to mean. Yeah. And Sue, I put together a list of the 30 questions that are on the list right now, so I thought I'd make you read through that. But it's actually kind of sadly funny when you look through the level of detail, because just imagine asking the employees all of those questions.
Well, I thought about it today because you had called about a vacation, and the person was very helpful on the phone.
Right.
But even so, a short survey afterwards, it's kind of like, oh, okay, well, I'll do it because he was really, really helpful.
Yeah.
But I don't think you would have answered 32 questions, no matter how happy you were.
That's exactly. I think it would be frustrating. So let's take a short break, and when we come back, we'll talk about OAS-CAHPS, patient satisfaction, patient engagement. We're going to have an interview with our friend Spencer Kelpe with Dialog Health to discuss patient engagement and some new technological advancements in communications.
The ASC Podcast with John Goehle would like to welcome our new sponsor, Dialog Health. With Dialog Health, ASCs nationwide and some of the largest ASC management and development companies are tapping into the power of two-way text messaging to greatly improve their patient and staff engagement. Two-way texting allows ASCs to easily and quickly send and receive information from patients' family members, staff, and vendors.
Why do ASCs love Dialog Health? Surgery centers are using Dialog Health to achieve clinical, financial, and operational improvements in areas including case volume and scheduling, patient collections, safety, pre-op compliance, satisfaction and online reputation, cost savings, emergency preparedness and response, and many more.
With text messaging as the preferred communication method for a growing number of patients of all ages, ASCs that leverage Dialog Health quickly realize that two-way texting is the communication tool they've been missing. Adding the Dialog Health platform is easy thanks to its streamlined setup process and integration with existing systems. It's HIPAA compliant, secure, and reliable. Analytics allow ASCs to monitor the performance of their text messaging campaigns and identify opportunities for improvement. And since Dialog Health is scalable across the enterprise, as an ASC grows, the platform easily grows with it.
Dialog Health is delivering real and transformational results for ASCs. Recent results include a more than 90% reduction in post-op phone calls, a more than 50% reduction in outstanding patient accounts receivables in just 6 weeks, and a more than 80% patient survey response rate.
To learn what Dialog Health can do for your ASC, visit dialoghealth.com and schedule your demo today.
So we're back for our part 2 focus segment. We're going to talk this week about patient satisfaction and patient engagement, as well as patient communication. So this is kind of the first time we've really delved into this too deeply. Obviously we talk about finance, we talk about, regulatory compliance, but with the 2022 payment rule starting the process of implementing OAS-CAHPS, I thought it might be a good thing to talk a little bit about OAS-CAHPS, and how that might fit in with patient satisfaction. So let's start. In 2022, the ASC proposed rule, CMS proposed the requirement that OAS-CAHPS, better known as Consumer Assessment of Healthcare Providers and Systems Outpatient and Ambulatory Surgery Survey, better known as OAS-CAHPS, would be implemented. So this is what the rule would be, is that these survey-based measures would have voluntary reporting for calendar year 2023 reporting period. In other words, you'd gather the data in 2022 and report it in 2023. And mandatory reporting would be required in 2023 and then reported in 2024. It gets even more confusing, Sue, of course, because then, so when you report in 2024, it'll be affecting your 2026 payment rule. So when OAS-CAHPS goes into mandatory reporting, if this proposed rule goes forward, you would have to do OAS-CAHPS in 2023. You would report it in 2024. And if you don't report it in 2024, your 2026 payment would be reduced by 2% of the increase. So let's start with the description of the survey.
The Centers for Medicare and Medicaid Services, or CMS, developed the OAS-CAHPS survey to measure the experience of care for patients who have a surgery or a procedure performed in an ambulatory surgery center.
So prior to the implementation, or prior to the proposal for the implementation of OAS-CAHPS, which, by the way, has been under development for literally 10 years, since about 2012. There was no standardized survey instrument to assess patient experience with outpatient surgery centers. And we know that because, all of our centers have different types of patient satisfaction surveys and different ways of doing it. For the most part, I think, certainly most of the centers over at Ambulatory Healthcare Strategies, they hand out a survey tool to patients before they leave. And we've always, I know you deal with this a little bit more than I do, we've always tried to keep those tools simple, like 5 questions, because we know once you go beyond 5 questions, it gets a little frustrating.
Yeah. And I think that's a good way to do it. And then if you identify an area that might need some strengthening, then you go ahead and you can expand that a bit.
Right.
But
like
you
if you find
start with all these questions.
Exactly. Like if you find that wait time is I guess that's the famous one that people are complaining about wait time. You might add a few more questions to your survey while you're doing maybe a quality improvement survey. So as we talked about earlier, we know that the more questions you have, the less likely people are going to stick around long enough to answer all those questions. Yeah. And that brings us to OAS-CAHPS. Now, I think OAS-CAHPS has a lot of good things going for it. Its purpose really is to have participating ASCs being able to compare their responses against their state and national average. And I think that's a very strong part of this. So in other words, if we use the standardized questions across the board for all ASCs, we'll be able to do real good benchmarking, across all the facilities in our area of our certain type, for example, maybe GI centers, which we can't do now.
Yeah.
So let's talk a little bit about what the survey consists of.
So they divide in the questions into several areas. So before your procedure questions, there's 2 questions about that. About the facility and the staff are 6 questions. They've got 5 questions related to communications about your procedure, 9 questions about your recovery, 2 questions about your overall experience, and 13 questions about you.
Yeah, right. And the last item is really to try to categorize the patient into different categories: age,
demographics, sort of things.
Exactly. Okay. So notice that there are 5 questions about communications about your procedure, which is one of the things we're going to talk about a little later when we have an interview, because communications is a vital part of this. I remember my daughter Jenna used to explain to me what she was doing when she was working in the hospital in order to improve their scores. Hospitals have a similar CAHPS program there. And they would get a lot of education at the hospital as to how to communicate with patients. In other words, the words to use so that those words matched up with the questions that were going to be asked. And we're going to talk about that in a second here when we go through that. One of my biggest concerns throughout the implementation of OAS-CAHPS is I don't want to lose the ability that we already have to focus on areas that are important to us, to ask questions that we've traditionally asked.
Yeah, and there you can. It says here that you can add questions to it,
right.
But I don't know how many people are going to want to add to this amount of questions.
Yeah, you can add up to 15 additional questions. So can you imagine, already I think there's at least 30 questions.
Yeah.
And then add another up to 15. I mean, even if we just add our 5 that we normally use, it would be overwhelming.
Yeah.
So there are 3 different ways that the survey can be administered. And again, we don't have a lot of details yet as exactly what's going to be in the final rule, but there could be a telephone interview. There could be mailed surveys. In other words, you mail them to the patient and then they return it. There's a variation of that where you mail it and then there's a telephone follow-up. And then they've also been working on a web-based version of the survey so that you can go to a website. And I imagine you would be sent an email after the procedure with a link to that.
To fill out. And of course, you'll have to pay a company to administer the survey. This is not something the center can do themselves.
That's right. And we do know that it's a 4-figure. I think I've heard that it's a minimum of about $5,000 a year to do that. Don't quote me on that, but check it out yourself. We're going to provide a link to the survey materials, but I thought it might be interesting, and I don't know if I'm going to say fun, but it is kind of interesting to go through the questions. So, Sue, you and I will alternate back and forth just so that everybody gets a feel for the types of questions that would be included.
And how probably onerous it's going to be to answer these.
So imagine yourself in these. So Sue, I put this in there right from the script. So this would be similar to if they were to call you on the phone. So just imagine going, where would you stop? Because that's what I do. I mean, if any survey takes too long, I just stop them.
So at what point are you just tired of it? So first question, before your procedure, did your doctor or anyone from the facility give you all the information you needed about your procedure? Now, probably in the web-based one or the mailed one, you would say yes or no, whatever. If they're calling you, it looks like they've got a script that would kind of follow through with that. Like, would you say it was good? Would you say, I don't know if they're going to use a number system or whatever.
And again, all of these things are still a work in progress. So the second question they would ask is, before your procedure, did your doctor or anyone from the facility give you easy to understand instructions about getting ready for your procedure?
And then I'll group a few of them. So did the check-in process run smoothly? Was the facility clean? Were the clerks and receptionists at the facility helpful? And did the clerks and receptionists at the facility treat you with courtesy and respect?
And then
number 7.
Number 7 is, did the doctors and nurses treat you with courtesy and respect?
And did the doctors and nurses make sure you were as comfortable as possible? I'm right now thinking I'm hanging up the phone.
That's right. Yeah, because there were so many repeating. Yeah, right. Did the doctors and nurses explain your procedure in a way that was easy to understand?
Anesthesia is something that would make you feel sleepy or go to sleep during your procedure. Were you given anesthesia?
So if you did the doctor or anyone at the facility explain the process of giving anesthesia in a way that was easy to understand?
And did your doctor or anyone from the facility explain the possible side effects of the anesthesia in a way that was easy to understand?
And then moving on to discharge. Discharge instructions include things like symptoms you should watch after the procedures. Before you left the facility, did you receive written discharge instructions?
And question 14, did your doctor or anyone from the facility prepare you for what to expect during your recovery?
Did your doctor or anyone from the facility give you information about what to do if you had pain as a result of your procedure?
At any time after leaving the facility, did you have pain as a result of your procedure?
And before you left the facility, did your doctor or anyone from the facility give you information about what to do if you had nausea or vomiting?
And sorry, just an aside, but I wonder if they're going to explain, like, a lot of people are going to have pain.
Yeah.
And that isn't always a bad thing as long as it's somewhat controlled. I wonder if they're going to break that down as, was it, bearable or something, because
yeah,
you're never going to have zero pain.
Right, exactly. And then, they talk a little bit. So there's this script. I mean, it seems to me like the script that we're actually running through, I only put the questions in. There's also explanations that go with it. So there's
we're only
no
halfway
way.
Through.
And we are only halfway through. So it just seems to me like there's going to be at least a minute for each of these questions. And of course, if we're asking an elderly patient, we always know that they tend to it's probably a bad generalization, but we just know from experience that often these conversations can carry on for a while.
Drag on. So before you left the facility, did your doctor or anyone from the facility give you information about what to do if you had nausea or vomiting?
At any time after leaving the facility, did you have nausea or vomiting as a result of either your procedure or the anesthesia?
And before you left the facility, did your doctor or anyone from the facility give you information about what to do if you had bleeding as a result of your procedure?
And then at any time after leaving the facility, did you have bleeding as a result of your procedure?
They give possible signs of infection, which include fever, swelling, heat, drainage, or redness. And before you left the facility, did your doctor or anyone from the facility give you information about what to do if you had possible signs of infection?
And then, of course, the next question is, at any time after leaving the facility, did you have any signs of infection?
And using any number from 0 to 10, where 0 is the worst facility possible and 10 is the best facility possible, what number would you use to rate this facility?
So that this begins some of those general,
more normal,
questions about the care.
Yeah.
Question number 24, would you recommend the facility to your friends and family? Which is probably one of those questions that we all currently do now. Unfortunately, it's question number 24.
And in general, how would you rate your overall health?
And then in general, how would you rate your overall mental or emotional health?
What is the highest grade or level of school that you have completed?
And then, so these questions, of course, these last questions here are demographic. Are you of Hispanic, Latino, or Spanish origin?
And what is your race? And they give you categories to select from.
So I think you get the point, that these are very highly nuanced questions that I think people will get frustrated answering. We do know, of course, the people that are most upset at the care will most likely be the ones that will spend a lot more time going through this.
Yeah.
So I think one of the critical things, Sue, is we're trying to find a way to improve patient satisfaction, even absent the OAS-CAHPS, is by improving patient communication. In other words, how do we communicate with patients before? How do we make sure that they're well prepared for the procedure and understand what's going to happen during the procedure and what will happen afterwards, what your discharge is going to be like. And I think the pandemic has really changed the way that we communicate with our patients.
Yeah.
One thing that we always had done in the past is we allowed family members to come back after the procedure is done and, be with the patient to hear the discharge instructions and to help the patient in recovery and make sure that the family member, hears the things that the patient might not hear. Because of either the procedure that was being just recovered from the procedure or, of course, the anesthesia implications of it. In many of our centers, for example, still the family members are not back yet. So good communication with not only the patient but the family members is extremely important. And, of course, with that, post-op communication is just as important. How do we communicate with them to make sure that they recovered well? That is an accreditation standard, for example, that we need to have good communication, or we need to communicate with the patient to find how well they recovered after the procedure. So as we move into the new era, Sue, when I was down in Texas, I was on a panel, and I think I'm going to mention this in a previous episode. I was in a panel talking about marketing. And a lot of that conversation talked about, how we have a social media presence, what happens in our websites. And I think it's very apparent right now that people are becoming much more comfortable with electronic communication, which means that we really have to start thinking in the surgery center as to how are we going to communicate with patients that are more comfortable with electronic communication, which means that we need to spend some time looking at our websites, making sure that they're useful to patients, and then looking at our communication prior. I think it's fair to say that telephone communication is starting to decline. I think most of us still rely on it, but I think we're going to be finding us using more websites, for example, for preoperative conversations about the procedure. We'll have asking our patients to log in and give us their health history from a website as opposed to getting a telephone interview. Now that's a slow process, and I don't know how long it'll take to move in that direction, but that's certainly the direction we're heading. So you need to spend some time looking at your website, determining its usefulness, and making sure that you keep it up to date. Likewise, with email, you need to, make sure that you have, if you're going to use email, that you do it in a proper way, that that as much as possible, you keep that information confidential. And now we're also starting to see texting. Now, the problem with both email and texting is that can be quite problematic from a HIPAA standpoint. Much more so than, telephone calls. At least you can try to make sure who you're talking to on the other end. So what we decided to do is we decided to call upon Spencer Kelpe, and he's with an organization called Dialog Health. Now, Spencer's company has a tool that would allow a HIPAA-compliant communication with the patient. But what we asked in this interview is to talk about patient engagement, the different aspects of it, the different times that we communicate with a patient, and how an electronic solution such as his, and there are many other, competitors out there, but specifically, how this type of a patient engagement can happen. So let's listen to this interview with Spencer Kelpe, and after that, we'll go into our section 3. So Sue and I are here with Spencer Kelpe. He's the Director of Key Accounts for Dialog Health. We're going to talk today about patient engagement, patient satisfaction, how to engage patients better in our surgery centers. Welcome, Spencer.
Thank you very much. Appreciate you having me.
So you work with a company that basically has a texting solution that helps surgery centers to find a better way to communicate with their patients. So we thought we would talk about what are different ways that we can engage our patients better? How can we communicate with them better? I think in today's environment, as we're starting to see more patients coming to the surgery center that perhaps might have been going to a hospital, for example, in the past, are finding the surgery center solution much better, since nobody wants to be in a hospital, with COVID. So why don't we start by talking about how we can actually improve clinical outcomes? I think, if we're going to start by talking about anything, let's talk about the most important thing. How can we actually improve the quality of care that we're providing to our patients and the outcomes that a patient has? So can you talk a little bit about your thoughts on that?
Sure. There's a couple of ways. And one of the most popular that we're finding is, since it's ambulatory, right, there's a lot of responsibility that's actually put onto the patient to prep, to make sure to remember their appointment, to what are they supposed to do before coming into their appointment? What are they supposed to bring? What are their COVID policies? Right. All of these sort of things we're asking the patients to remember or do. So I'd say if you want to improve clinical outcomes, the best place to start is educating them or hitting the easy button really for them before they ever even come in for their appointment. And the best way that most people today in their busy lives find that is just texting it, right? Give me a text reminder when I need it, when I'm supposed to have it, that, hey, you have an appointment. Are you still coming in? Have you forgotten about it? Did you schedule something else? You're going to be out of town.
Do you know what time it's going to be?
Right. Yeah. And then also links, right? So most people, when they have a cell phone these days, they don't just have a flip phone that texts, right? There are populations that do, but most even have smartphones. They've got iOS or Android. So you can hit the easy button for your patients by click this link. Here's all the things that you're supposed to do for your prep before you come in. Or here's the paperwork we're going to ask you to bring whenever you come in, those sort of things. Or if you need to reschedule, click this link. Let us know, not just that you're not coming in for this appointment, but we also want to keep you in our network. So let us know when you can come in. When would you like to reschedule? So, improving clinical outcomes by doing those sort of things, that's going to improve a lot more on-time starts. Also, one of the big headaches that ASCs will deal with, and pretty much any operational person will tell you the same thing, is no-shows, 24-hour cancellations, no-goes, right? Those sort of things. So, by just simply communicating a little bit better, a little bit more conveniently from the patient experience, you can improve those outcomes. And then by putting in those things that we talked about with the, hey, here are your instructions that you're supposed to do. This is when you're supposed to start your prep. remember, no coffee tomorrow morning or anything until after your appointment. Sending those pieces of information at the right time, like the evening before when they're sitting down for dinner, that's a great time to improve those no-goes or non-compliant patients as well. So I'd say start there before they ever get into your care, before they ever come in. That's where you should be starting that communication piece. And then you've got them in your database. You've got them used to texting and communicating the way that you want. So if you progress a little bit further, hey, here's an easy way to pay your bill. Here's an easy way to remind you that for your colonoscopy, your endoscopy, these things that are recurring events that may happen every 1 year, 5 years, what's the best way to let them know? Hey, records show it's time for you to go ahead and schedule this. Continue it with that text.
Just going to say, it does seem like most centers that we work with, the biggest cancellations are either the no-shows or often people that forget they can't have their coffee in the morning or they can't have any breakfast. So, that could really improve things quite a bit.
Well, and if you think about the history of the way we engage with people, I am so frustrated with email right now because, you and I are doing this interview. I'll be away from the email for about an hour. When I go back, there'll be 100 emails that will have accumulated. Needless to say, things get missed. I throw things out in my email that I probably shouldn't. And so much of our email just, distracts us from trying to get things done. And of course, before that, we had telephone, and then we had the mail. Nobody uses the mail anymore for this type of engagement. And telephone, people frankly don't, answer the phone unless it's a number they know. Mm-hmm. So I think you're right. I think the next genesis is going to be, the next transition is going to be toward more texting, where we have much more patient contact, especially with cell phones getting to the point where, as you said, you can put a whole bunch of links in there that they can use to immediately respond to any of the things that you've indicated need to be done prior to the surgery.
And I would say, so kind of walked over this and we said, yeah, I think the future will be texting. That'll be the next thing. It's not the next thing. It's already here. Right. Well, the people are already saying hey, this is how we communicate, not only with our friends and family, but this is how we expect to communicate with businesses, the restaurants where we make appointments. And hey, if we're online shopping, what are my delivery updates? What's all this helpful information that I can just take a quick peek at, right? And it's not going to interrupt my day. Right. So that's the only thing that I tell people when they're saying, yeah, I think this texting, that really is the way to go, right? That's the future. Yeah. It's already here. We're just a little bit behind. We're just catching up to it.
Well, and I want to put this also in the context of quality improvement here. And again, just for our listeners, if you're going through your quality improvement and you find that your satisfaction, well, a couple things. First of all, as Sue mentioned, if your cancellation rates are going through the roof, if you're finding that you can't get a hold of patients beforehand, that's the type of data you should be collecting up front is, how frequently can you communicate? Can you connect with somebody by telephone beforehand? If that number is dropping, then it's time to start thinking about other solutions. Likewise, if you're finding your cancellation rates going up on the day of surgery because people did not do what a telephone call would have told them to do beforehand, or what they were given instructions in the office to do that they just flatly forgot, then that is, again, another time to start thinking about other ways to engage with the patient beforehand. So I think, Spencer, you hit it right on the nail there, right on the head there, this is something that I think you're going to find those numbers increasing. And you need to keep a track of it through your tracking and trending methods in your QAPI program. Mm-hmm. So that kind of leads us into the next area, which is improving staff workflows. It kind of does tie into it. Why don't you tell us a little bit about how you think this new way of engaging with our patients, or expanding the way that we're already engaging with each other into the healthcare field, can help improve staff workflows?
Think about what the current workflow is today, right? For a lot of people, it's, okay, I'm going to look in my schedule. If I have 30 cases today or 30 cases on Friday or whatever it is, you look into the schedule and then you start picking up the phone and dialing people one by one. So you look up the record, pick up the receiver, dial 10 digits so somebody answer. If not, leave a voicemail. And that's only if they'd have a voicemail where the voicemail box isn't full or set up yet, right? And you're like, great. Now this will be a, red flag for a non-compliant patient coming in again. Versus, so if you take that and then just say, hey, before we start picking up those phone calls and calling people one by one, I'm going to quickly look into a software, a solution to say, how many of these people got texts that said, hey, are you coming in? How many didn't get that text? Maybe they don't have a cell phone number, but I can quickly and easily see who does or who doesn't. How many phone calls can I, remove? And then from there, if you've got, say, two-way texting, in my opinion, way better than a notification system that just says you have an appointment. But now you can actually see the people who said, yes, I'm going to confirm this appointment right now, right? Or no, I don't need any follow-up assistance after my appointment. I'm self-identifying on my own time and at my own convenience. I'm okay. So now before you go in and start doing, hey, I'm sending out all of my emails or I'm making my phone calls one by one, do a quick scan. How many of those have I eliminated? If you eliminate 25 out of those 30, well, great. That's time savings. That's just going to compound every single day. So that's the immediate thing that I think is, from the staff perspective, is just that time savings of, I don't have to just keep throwing more resources because my metrics are increasingly getting higher in terms of no-shows and no-goes or, follow-ups or readmittance or those sort of things. So you don't have to throw more resources at it, right? You can just install a technology. You offset some of those.
Yeah, and especially when we're in an era right now where our nursing staff, who are often the ones that are making those phone calls. Now, depending upon your organization, that might be different. It really doesn't matter, though. I mean, we're all short on staff right now, and the more that we can improve the efficiency of the nurses, so that they're every time that they make a phone call that they don't get through to a patient is wasted time. Here, I think what you're saying is that, that if the system can make that connection so that the patient then calls, or that you're going to have a live number to call afterward, after the text message goes out, that's going to improve the efficiency of the nursing staff that are making those pre-op phone calls. Actually, and the same thing can be said. I know we're going to talk about that in a bit, the post-op call too.
I mean, that's a perfect segue, right? So that's a lot of places where ASCs, they go, you know what? All of this stuff that, Spencer, you mentioned before an appointment, that sounds really, really, really nice and good, but we need more bandwidth. That is our pressing issue. That's our burning deck. What's the number one thing you can think of to save staff time? Do you do a post-op check-in? Yes. Okay. Do you call 100% of those patients? Yes. What if I could remove 80% of those? Okay, that's where we're going to start, is just, you don't need to call everybody to find out who you need to call. Find out who you need to call, then call those people. And it's probably like one or two, right, on any given day. And then the other thing that I find too with these businesses is, if you've got, say, a recall program, or if you've got mailers that go out to people, or you're emailing, it's hard to track the metrics of a mailer or how many of these phone calls were successful. Right? You made the phone calls, but it's much harder to track those sort of things. And I think data these days is starting to drive a lot of the business decisions on, how do we become more efficient? How do we get a better patient satisfaction? How do we improve our benchmarks? So if you've got a technology and a solution in there where everything is logged, it's easy to say, I'm calling everybody now, our no-show rates are 10%. Yeah. I added texting. Is it easy to quantify? Yeah, that went down 20%, 10%. And I think that's the added benefit of workflow efficiencies on top of just not making phone calls. You can look at the data that you've got in your system and say, well, this worked well over here. Could we also apply this over here? Could we apply it to bill pay? Could we apply it to post-op? Could we apply it to recalls? All of these different types of programs that you're looking for. If it's in a trackable solution, it makes it easy to just start compounding efficiencies on top of efficiencies.
Well, and let's point something out here too, is that the standard texting solution that we all have, using your cell phone, is not ideal for this, because we still have to have documentation of that post-op engagement as well as the pre-op engagement. So whatever system you have has to have that capability of documenting that interaction that you have, or the computer had, with the patient, so that you can put that into the patient chart afterwards, both the pre-op and the post-op side. So I want to point that out as a surveyor, as a AAAC surveyor, of course, is the importance of making sure you have good documentation that you followed up with the patient after the procedure was been done, even if it even if it wasn't a real person. If everything was perfect, as you mentioned, Spencer, if everything was perfect, then the computer, the message went out, did you have any complications? The patient texts us back and says, no, everything was fine. That's great, but you still have to have documentation of that, which a standard texting solution is just not going to have for you.
Right. Just from somebody's cell phone, right? CMS comes on site and says, hey, show me your post-op check-in. Oh, Susie texted her.
Not to mention the whole issue of
that somewhere, right? Versus, if you've got a real, be it some sort of connection from your EMR, your scheduler, there are places that offer, solutions that are robust and in terms of, hey, we do all kinds of things. And then there's ones that just say, look, we're going to automatically log it. You've got your dashboard. You've got everything you can see here. CMS comes on site, says, hey, show me your post-op follow-up for Derek for Wednesday. Okay, here it is. Done.
Ultimately, all of this leads into patient satisfaction, though, improving the patient experience, making sure that the patient has good things to say about us afterwards, especially as we move into the era of OAS-CAHPS, where CMS is going to require us to not only do patient satisfaction surveys, but really track it in a consistent way across the country. So as we move into the OAS-CAHPS areas, that's going to take effect in 2023. We really want to have better ways of making sure that our patient satisfaction remains high. How can these alternate communication systems help improve patient satisfaction?
I think it goes hand in hand with everything that we've been talking about so far, with hitting that easy button in terms of their communication, right? Because from a patient experience, if they don't remember to do their prep work, if they don't remember to show up on time or get delayed, or they drink their coffee, while it's their fault, right? You told them, hey, this is what you're supposed to do. If they forget and they show up, now they've blocked out their time to come in. They've taken off work. They've showed up. They've come in and they can't do it. That's still a negative experience, be it their fault or otherwise. They don't really care, right? And that's, one of the ways is just saying, look, we know and accepting and empathizing, you have a busy life. This is something outside of your normal day-to-day that you're already doing. This is an extra step. We need to make it as easy for you as possible. Those sort of things. And I would say it goes all the way through. Hey, I don't have to step out of my meeting, see who's calling me. It might be my doctor. I got to see if it's important, or I'm waiting on results, right? Just hey, I'm in a meeting. Great. I've got my update. Do you need us to give you a call for any reason? No, you can handle that in a meeting. Mm-hmm. And then the same thing with bill pay. So personally, not only do I work in the space of texting and healthcare and all of those sort of things, but I've got a daughter who's 3 and a daughter who's 1, and pediatrician appointments are all the time. And I'm very guilty of being caught behind. And the pediatrician just texts me, hey, you owe $160. Click this link and pay it. So it's not even, there's a bill waiting for you to view and this and that. They just flat out say, you owe this much. Can you pay it right now? And for me, in my experience, I could just check that off the list. That's one less thing in my, busy life that I've got to think about, or, is occupying space in my head. I can just get it done, click the link right from my phone, move on. Right?
Without pulling up another app or worrying about another. I don't have to pull up an app. I don't have to go to a computer, right? Look things up. I'm not pulling a piece of mail. Where did it go? And there's a website. Let me type it in here with no typos, or I forgot my username or my password. But it doesn't exist. Just click here. Your phone's going to remember that username and password. Click, done. And now I'm back to eating my salad at lunch or whatever I was doing before, right? There's no interruption. It takes 2 minutes. So all of those sort of things as well. The more things we can hit the easy button on, the better that patient experience becomes. And those satisfaction surveys go hand in hand with it, right? It seems to me too that this is instantaneous. We know when we send out surveys, for example, patient satisfaction surveys at the end of the month, or under OAS-CAHPS, where we might, we'll get the results 30, 45 days afterwards. That's a long lag time to get that information. Aren't you also suggesting that this is a much quicker way of getting this information back almost in real time?
If you do it by text, It's absolutely real time. There's a real time. So a lot of ASCs that I work with will say, hey, can we just do like a 1 to 5 rating? I mean, the surveys and the scores and all of those things, those are good. We definitely want to improve those. But as a facility who's looking at and earnestly trying to improve that patient experience, we want the real-time feedback loop, right? Mm-hmm. 1 to 5, how's your experience?
And fill this out before they fill out the OAS-CAHPS survey. In other words, that way you can get the feedback, you can figure out whether there was any misunderstanding that resulted in that bad rating. Maybe calm them down a little bit. Whatever needs to be done in order to make them happy if something didn't go quite perfectly during that event.
Mm-hmm. Well, that's one of the human elements of things. If you go, buy a car and you just buy a car, you just walk away and you go, my experience was okay. But for whatever reason, if you go buy a car and something was wrong and that dealership says, no, bring it back in, we're going to take care of it, and they fix it and their due diligence, you feel like you had a better experience.
You turned it around.
Exactly. That works, right? So same thing with surveys as well. You start to see those types of responses. Anything you'd like to add to that? I felt like they really cared about my experience, and there's an issue and they jumped on it right away, and they wanted to make sure that I was completely taken care of. So having that opportunity also gives you that improved boost when you've got the real-time ability to see, hey, this is, the issue. We can resolve it very, very quickly.
So Spencer, I'm old. Sue is, of course, a lot younger than I am, but personal touch, it just seems to me, I want to be on the phone with somebody. I want to talk to somebody. Now, I think there's a couple problems with that. First of all, as I said, I'm old. And second, the world is moving on, and let's talk a little bit about that. I mean, I think there's a lot of myths out there about how this type of communication could be impersonal.
I love the personal touch because, as you pointed out, it is a myth. The things that are moving, the way that communications and personal touch are moving on that continuum of, it's becoming to the point where if it's not already there, if you're calling me, you don't know me. You're not in my inner circle. Mm. Nobody calls me, right? If they're in the inner circle, they text. They know. So the businesses that I work with, my Amazon, they text me updates, and my delivery driver doesn't call to see when I'm going to be there. Just, hey, your package is going to be delivered around this time. Mm-hmm. My friends and family, hey, this is what we're doing. Okay, great. Now we don't need to call and plan it out. So that inner circle really is the text and the technology. But let's just for a moment say, okay, but there's a population where that's not true. When you said, hey, I'm old. I prefer a personal touch with the air quotes that I'm doing on here. Let's not say that we are forcing everybody to text. Right? You're just adding another communication channel. You're adding another option for those patients to be able to choose, how do I prefer to be communicated with? So the standard TCPA compliance is you have to let them know, hey, you're being opted in for this. We're going to give you some valuable updates and ask you questions, or this is a communication channel for us, but you can reply stop at any time. So that's the thing that I always want centers to understand when they're making a decision like this, is that you're not, by saying, hey, I think that they prefer a personal touch, you're making that choice for your patients, and it might not be the right call. And you have to be, and if you are making that call, you have to be at least 50% accurate or better, right? If I'm going to make this hard line, at least I want at least half of my patients, or 51%, to like it more than the other. Otherwise, I'm wrong. So texting, it just gives you the option to say, for those who want text, great, they're going to remain opted in and they're going to text. For those who want a personal touch, they're going to opt out and we're going to be calling them, right? So, with those things, first off, the personal touch, believe it or not, it now is the text. That means you know how to communicate with me. You're in the inner circle. We can go back and forth and I will let you in. If you're calling me, you're probably 80% likely I'm going to screen that call, 80% chance. So then moving the other way too. And I don't want to ignore the fact that nobody who is in texting, I don't think, if they disagree. Maybe you run for the hills, but I don't think anybody would say, hey, every communication should be a text.
Yeah.
No, it just gives you another tool in your tool bag.
Well, it seems to me too. I mean, you're absolutely right about, when you get a telephone call, you have to answer it right away or listen for the voice message that comes after it. With a text, you can choose to answer it now. You can choose to answer it later. A lot of people, and myself included, right now, as much as I say I'm old and all that, taking phone calls when you're getting, hundreds of communications a day from people literally just kind of interferes with your daily schedule, because those are things that they're not on your daily, calendar as to who you're going to communicate with at what time. They're interruptions.
It's an interruption.
Yeah. Can you talk a little bit about the different demographics that we run into? Is your experience that older people have more of a problem with these types of texting solutions than younger people do? I mean, I think we can all agree that younger people have no problem with this communication. What's been the experience with older people?
So there is a line there, but I don't think that line of differentiation is where everybody thinks it is. Mm-hmm. I think that when we group people, we forget to include ourselves in those data sets. Yeah. I'll talk to physicians and doctors and go, I don't know. I don't think people over 50 text. Oh, sorry. How old are you? Yeah. I'm 70.
If my 90-year-old mother can, right? If my 90-year-old mother can text, anybody can text.
Except my mother.
Right.
But that's okay.
Oh well.
Yeah, she doesn't look at her email or answer her phone either, so I don't know.
My grandma, so she is. We just went and celebrated her 86th birthday, and she texts. Yeah. Purely so she can get photos of the grandkids.
Yeah.
That's it. So
that's exactly right.
The rest of the stuff, she could take it or leave it. Doesn't want to miss out on those photos. So, is it her preferred channel? The answer is no, right? She still prefers a phone call, and she likes that. But she is texting, and she's not going to miss out on that channel, right? Because there's an opportunity lost there for her, since we don't live close by. But when it comes to texting, yes, there are things to the age demographic. There is a drop off there, but we are talking about saying, okay, if you're like 70 plus, so up to 65, it doesn't matter. That demographic, those are the people running your companies and running the country and doing all of that. They are connected. They're in. So once you get into the upper echelons of, 70s, 80s, now we're talking there's a drop off. So that's the first thing to know is like, what percentage of your population is in that bucket, because that's where you'll see that drop off. And when I say drop off, I'm talking about, hey, 98% of Americans have the ability to text. Whether you have a smartphone or data plan or not, you've got the ability to text. And the drop off goes to like 92%.
Yeah.
So hey, if you're getting screened 80% of the time, what if you could just get a confirmed delivery rate or confirmation 80% of the time? So you flip your, hey, I can only connect 20% of the time to I only didn't connect with 20% of the people. That's a massive shift.
Yeah.
So there's not a big risk to doing something like this because you still have your phone. We're not taking your emails away. Yeah. If you do something like this, you've got all those channels. So yeah, there is a drop off. It is real, but it's not this big, chasm that people think it is. It's not this huge gap. There's a small drop off.
Yeah. Now we talked about how, this is not something you can do with your cell phone. This is not something that you can do with your, you don't take a bunch of nurses and say, hey, here's a cell phone for you. I want you to use this for company business and text all the patients from it. Well, first of all, talk about the reasons why you can't do that. And then talk about how do we choose a solution out there? There's a lot of options available, new options coming out every day. So start with why can't we use a cell phone and then transition into what should we be looking for when we're looking for a different solution?
There's so many reasons why you can't use a cell phone, namely because as a business, how do you control that? Yeah. How do you control and monitor what's being sent back and forth there? So that's a huge risk. If you've got a personal cell phone, well, it's a lot easier to lose a cell phone, for example, than it is you can't lose the internet, right? You don't have that ability to just go, oh, we've misplaced this. So,
and there's no documentation trail. There's no easy documentation trail. You can't separate it out by patient. And then by the time you have, 2,000 text messages, you got the same problem that you had with the emails before.
Right. Exactly. Right. So when you think of that documentation and where do you house all of that? And then, are the messages being encrypted in transit? Are they encrypted at rest? Who's securing all of these? You're going to want a standard and a staple when it comes to the protection and all of the compliance regulations. You got to have somebody who's checking all of those boxes and making sure it's up to date. AT&T isn't doing that. They're telecommunications. They're not in healthcare, right? So you want a healthcare company that's got that technology in there to make sure that they're keeping you compliant, right? And then to all of the points that you said too, with, hey, where are the records being kept and all of those sort of things. And then from a workflow standpoint, I mean, think about that as well. You have a solution where you could use your keyboard anytime you go and you can text back and forth. You've got a dashboard. You can see all of the responses that you're looking for. You can parse them out. Can't do that on the phone. You're texting individuals, right?
Well, and if you have more than one person that's doing it, how do you coordinate those different? How do you make sure somebody doesn't call the same patient?
Right. It should be in a singular dashboard so that there's that transparency. Everybody knows what's going on, and you've got that accountability in there as well. So. And then to your point, some of the things that you should look for in a good texting solution, I think automated messaging is the number one, right? That's number one with a bullet. That is, whenever you've got the case that gets scheduled, you should be able to automatically send out messages before or after. So if it's part of your EMR, your case management solution, these sort of things, it'll automatically integrate. If it's not part of that, if you're doing another vendor, make sure it integrates. Mm-hmm. So your staff now is just saying, hey, we put in a case. We're just removing all the phone calls leading up to the appointment and the follow-up afterwards. And the dovetail off of that is that I think that a good solution is not going to be a notification system. It's not going to be one-way communication of you just giving updates. We are asking for data back from you as well, because we want you to be able to self-identify if you're not having issues, if you don't understand your instructions, if you do need a call from a nurse or anything you're unclear of. We want to be able to see that and see if it's triage. The next thing that I would say 2 more checkpoints really on a good solution, in addition to what we've already said, is what about the ability to individually text or respond to a patient? So I've called you once, I've called you twice. Now what? You have a voicemail you're just stuck, right? You can't get in. You have an unreachable patient. But if you have the ability to one-off text an individual, you could say, hey, this is who's calling you. Yeah. It's your care provider, right? This is me. I've got important information. I can't text you necessarily, right? We're not trying to make everything in text, but I got to have a phone call with you. I'm calling from this number, or call me when you're available. So you can reach unreachable patients in that way as well. And then the final good checkpoint that I would say is, what about your one-to-many? So it's not automated necessarily, but if, hey, we've got a blizzard, hurricane, flash floods, wildfires, doctor is sick, whatever the case may be, how do I update a large subset of those patients other than calling them one by one?
Well, and especially if you're not in the surgery center, like we live up in the Northeast, the major storm here, of course, caused a lot of our centers to have to shut down and cancel. And if they didn't take that list of all the patients before they left that day, to make those phone calls, they're in trouble. Somebody had to go into the office to make that call. Now, of course, modern computer systems and modern EMR systems probably gave them access to that remotely. But again, without an automated solution, you're making 45 phone calls if you got 45 cases scheduled for the day. Automating that is going to be great.
That's something that most people don't even think of, right? You thought of that one right away.
Yeah.
A lot of people don't even think of that. And I think that for a fundamental system, that may not be necessary. I know that's a differentiator with us, that's what we bring to the table is, oh, guess what? You have to cancel all of your appointments for tomorrow morning because you know you're going to be snowed in. Don't go run into the office before the snowstorm really hits or this. Stay on your couch. Keep your red wine and your popcorn and your movie going. Just log into the system. You've got the internet, so just log in and all of those. So, software as a service or cloud-based or remote access, that is a definite plus.
And the reason I went that way, Spencer, because I was the guy when I was the administrator who had to make those 45 phone calls or who had to go into the office to get the list of all the patients because he didn't know that there was going to be a snowstorm the next day and didn't bring a list home with him. Yeah. But obviously we have different solutions today, but often it still means a phone call unless you have an automated solution. That I agree.
That's something that blows people's mind when, they go, how do we set this up? When are you going to be here? When are you going to do an on-prem setup? And how many computers can we put it on? No. We're going to hit the easy button. You want to hit the easy button for your patients. We're going to do the same for you. And just make it, if you've logged into Amazon before or any other online account, it's exact same sort of deal there. So that one I would say you teed up.
Well, Spencer,
that was on your checklist of things to hit that easy button.
So Spencer, I've got a tiny little surgery center. I only do 5 cases a day, 3 days a week. I can't afford this type of solution, right?
Nah. The good thing about these solutions, so whether it's ours, another one, pricing wise, I think should be scaling. So it should match. You should have the ability to set up a program that works well for your facility. Yeah. And that includes cost and budget, right? Just as much as functionality. But I have seen time and time again, without fail, if you're making an investment in something like better communication, texting, these are not expensive setups. Mm-hmm. If they are, they shouldn't be. You need to go somewhere else. You need to shop the market. But the return is there. So there are few products or services for a business that are going to meet 3 standards. One is, from the top, from the board of your ASC, they want to know, does this make me more money?
Yeah.
Yes, absolutely. If you're not having 10% of your schedule fall off because they aren't compliant or they didn't show up or they went somewhere else after they scheduled with you, that directly makes more money. Hey, can it, improve our workflows? Can it reduce our cost? Can it do all of the things that my staff also wants it to do while it's making me money? Yes, right? Texting can do that because it's just very, very simple, very affordable, and it in itself is an efficiency. It's built to be quick, easy. An SMS, which is a text, is only 160 characters.
Yeah.
And then the last thing that box that it checks is, can it do all of that without sacrificing the patient experience? And as we talked about earlier, it actually improves the patient experience. You're going to get better satisfaction scores. So if you're the administrator who was in charge of managing vendors as well as staff workflows, help me out if you can name a product or service or a vendor who actually could deliver on all of those. It produces an ROI. It actually reduces costs, improves the workflow, and improves the patient satisfaction. That's hard to find, especially at a price point that's quite reasonable.
Yeah. So, the scalability, looking into the scalability of the product is extremely important because hopefully that one place that does 5 cases 3 times a week is going to grow into the big oak tree that, does 300 cases a week. But if you have to change solutions in the process, then, you've wasted quite a bit of time.
Yeah. For me, that's a checkbox that I love because I've seen the value of that over and over. Yeah. Hey, we've changed case management solution systems. Hey, we've changed our EMR. Hey, we've changed schedulers. Hey, we've changed billing softwares or whatever. Well, great. You don't have to throw the baby out with the bathwater, right? You don't have to throw out all of your history of communications and records and things like that because you changed one of your vendors. So being a platform agnostic it's not the baseline fundamental that you need when you're looking for a good software solution, but it certainly helps if and when a business decision like that is made is, well, great, here's one less thing we have to change.
Spencer, this has been great. I mean, we don't always talk a lot about patient engagement on the podcast, so I think it's about time that we have this conversation. So I've enjoyed our time together. Thank you.
Thank you very much. Thanks again for having me on. Really appreciate it.
Sure.
In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
So our upcoming ASC Conditions for Coverage conference will be on October 22nd, 2021. For more information about it, go to ascpodcast.com. And Sue and I, the conference will be on a Friday, and we're going to go through over an 8-hour period all the conditions for coverage and the interpretive guidelines. I'm kind of excited about it. I guess it kind of sounds boring, but it really isn't. I think as you go through these things and as we talk about some of the experiences that you might have with surveyors, or as we discuss, what surveyors would be looking for, I think it could be quite helpful. And as we mentioned earlier, really, this is a conference that could be for everybody, whether you are an owner or an employee or considering buying a surgery center. This is definitely one of those conferences that everybody could use.
And the Washington Ambulatory Surgery Center Association's annual education conference and trade show is November 4th and 5th, 2021 at the Tulalip Resort and Spa in Tulalip, Washington.
And again, I apologize to Washington State Association. Unfortunately, I had a conflict. Otherwise, I would be speaking in that at that beautiful resort up there in Washington. And the Pennsylvania Ambulatory Surgery Association's annual meeting is November 8th, 2021 at the Hershey Lodge in Hershey, Pennsylvania. And unfortunately, we generally go to that conference, but we're going to have to skip that one this year also.
The 2021 Ambulatory Surgery Centers Congress is November 8th and 9th, 2021 at the Area Resort and Casino in Las Vegas, Nevada.
And I'll be speaking at that conference. I guess I better make my plane reservations for that. I just remembered. The ASC Director of Nursing Boot Camp, the November cohort presented by the ASC Podcast with John Goehle, will be November 16th through the 19th. It's going to be presented virtually. It is a follow-up to our May cohort. And all of our boot camps, of course, have been very popular, and they're always sold out. So for more information, visit ascpodcast.com. We did open up another 25 slots for the boot camp, so there should be plenty of availability if you sign up soon.
And ASCA 2022 in Dallas, April 27th through the 30th. 2022 is the live ASC Association Conference is back. John will be speaking, and there will be a special track for new ASC administrators. For more information, go to ascassociation.org.
And don't forget to visit our website at ascpodcast.com for a list of all of our past conferences, which you could get a recording of, as well as upcoming conferences. And also a reminder for everyone to become a patron member of the podcast. The patron member program, which is also known as ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. Resources include access to some of our virtual conferences, weekly drop-in sessions with myself and other members of Ambulatory Healthcare Strategies, various links to information online, policies and procedures, forms, example drill kits, and discounts on services and books, as well as access to AEU credits. Membership helps to defray the cost of producing the podcast, including research, staff, travel costs to conferences, equipment costs, and production costs. For more information, you may visit ascpodcast.com. Well, that's it for this episode of the ASC Podcast with John Goehle, and please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Caloritis, Amy Durbano, Lori Rodericks, and Ann Geyer. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Dialog Health. Dialog Health's business text messaging platform is transforming patient engagement and employee communication. For more information about how Dialog Health can help your ASC, visit dialoghealth.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.